Welcome back to part 2 of adverse complications of blood transfusion. We're going to talk about the other immediate complications of transfusion: the febrile non-hemolytic transfusion reaction, transfusion-related sepsis, allergic reactions, transfusion-associated circulatory overload, also known as TACO, which always makes me laugh, transfusion-related acute lung injury, known as TRALI, and massive transfusion. The febrile non-hemolytic transfusion reaction is the most common, and this is defined as a rise in temperature of 1 degree centigrade or 2 degrees Fahrenheit in association with the transfusion, and there's no other identifiable cause. This is caused by antibodies to transfuse lymphocytes, granulocytes, or platelets. Usually occurs in repeatedly transfused or pregnant patients. It's usually benign, but this may be the first sign of an acute hemolytic transfusion reaction. So stop the transfusion and initiate the workup. The prevention is pre-storage leukoreduction, which has decreased the incidence of these types of transfusion reactions. Pre-medicate with antipyretics, not aspirin. Aspirin acts as an anticoagulant, so you do not want to add that because that could cause problems if acute hemolysis does occur. Transfusion-related sepsis is bacteria growing in your blood. The signs and symptoms of this type of reaction occur during or shortly after transfusion. Fever, particularly those 101 degrees Fahrenheit or above. Shaking chills, I call this shake and bake. You're freezing cold and you're shivering, or you're just really, really hot and sweating profusely. And hypotension, which is a decrease in blood pressure. Stop the transfusion immediately and start the workup. This type of reaction may progress to shock, hemoglobinuria, DIC, and renal failure. Transfusion of bacterially contaminated platelets is the third most common cause of transfusion-related deaths. Now, we're not just talking about a reaction, we're talking about a fatality. Life-threatening sepsis due to platelet transfusion is 1 in 100,000. Immediate fatal outcome due to platelet transfusion is 1 in 500,000. So you'll want to review the bacterial contamination of platelets webpage. And what you need to know is that we do not transfuse healthy people. We are transfusing sick people. So a normal person may be able to fight off this type of bacterial contamination, but sick people cannot. And so some of them will die due to this type of reaction. The bacteria may enter the component containers or contaminate the port of the bag during donor phlebotomy. And if you look on the left-hand side, you'll see there's a big plug of skin. We use a 16 to 18 gauge needle. So you can see on the upper right left-hand side the plug of skin in there. And notice that the phlebotomist is not wearing gloves. This is the only type of phlebotomy that I'm aware of that wearing gloves is only mandatory for those in training. Because everybody gets tested, fully tested, all the donors. So that's donor phlebotomy. For component preparation, if you look at that first picture, they're thawing plasma in the sink. You never, ever, ever do that. And the water is not sterile. So if the water gets in the ports, which I wish they had a better shot, it's at the very top. That's where they'll insert the IV needle, or they'll spike the unit to where it will then flow through the tubing into the patient. So again, you never thaw frozen components in water. On the right-hand side, you see what is a thawing device that's approved. And what we do is we put the plasma or the cryoprecipitate into a bag, and then we insert it into a slot into the thawing apparatus. And it's at 37 degrees centigrade, and it will agitate, which will allow the plasma to thaw in about 30 minutes. When a patient has been identified as having sepsis due to a transfusion, our biggest concern is that components from the same donation may be contaminated. So they need to be pulled if they've not been transfused already. Platelets are most commonly implicated, and you can see each of these components are contaminated with bacteria. Prior to release, each unit must be inspected, and it's documented in the computer. And you don't spend 30 minutes looking at it. Once you've seen 100 to 1,000 normal units, if you have one that appears abnormal, it sticks out like a sore thumb. So what are you looking for? A purple color. Clots in the bag, and you can actually see these. And that could be an indication either of bacterial contamination or they didn't mix the blood well during the collection process. And hemolysis, especially sprigs closest to the primary bag of a red cell unit. So if you look at this picture, you can see that, well, just know that the picture on the left is a normal looking unit. The picture on the right is full of gas. What do bacteria produce as a byproduct of metabolism? Gas. So this would just catch my eye immediately and would not be going anywhere. Urticaria is an allergic reaction that is commonly encountered. It's characterized by local erythema, hives, and itching, and usually without fever or other complications. If localized urticaria is the only manifestation, it is usually not necessary to discontinue the transfusion. The etiology is unknown, but it's thought that perhaps the plasma proteins are something that the patient reacts to that causes the skin condition. If a patient is known to break out in hives during a transfusion, pre-treat them with antihistamines because, again, allergic reactions involve the inappropriate massive release of histamines. And I also want you to memorize that this is the only type of transfusion reaction. If it's urticaria only, the transfusion can continue. And that would be a policy put in place at your facility. The most feared type of allergic reaction is anaphylactic shock. This occurs after the infusion of only a few milliliters of blood or plasma and the absence of fever. The onset is characterized by coughing, bronchospasm, respiratory distress, vascular instability, nausea, abdominal cramps, vomiting, diarrhea, shock, and loss of consciousness. And the respiratory is the most concerning because these antibodies cause swelling or edema of the tissues, especially in the lungs and the throat, and the face swells up. Remember in immunology, serology, we talked about this type of reaction. These reactions may occur in IgA deficient patients who have developed anti-IgA antibodies, and this is after an immunization by a previous transfusion or pregnancy, because all normal people have IgA antibodies in their plasma. Stop the transfusion immediately. Start the workup. Approximately 0.5 to 1.2% of the U.S. population is IgA deficient, but not all of these will make anti-IgA. Once identified, though, the sensitized IgA deficient patients must be transfused with blood and blood product that lack IgA for the rest of their life. Transfusion-associated circulatory overload, also known as TACO, is the #1 cause of transfusion-related deaths. Previously, it was TRALI. As I researched for the most current statistics, over the years, TRALI has been #1, but for this cycle of 5 years, TACO is the #1. Hypervolemia must be considered if dyspnea, severe headache, peripheral edema, or other signs of congestive heart failure occur during or soon after transfusion. A rapid increase in blood volume is poorly tolerated by patients with compromised cardiac or pulmonary status, and we need to use common sense. We had a lady come in. She was an elderly woman, 4-gram hemoglobin, not compatible with life, but she walked in, but she was real short of breath, and she said, boy, I'm really tired, and she was weak, so we did an H&H, and again, 4-gram hemoglobin. So she desperately needed a transfusion, and the symptoms of this type of reaction are coughing, cyanosis, lack of oxygen causes the tissues to turn blue, orthopnea. When you lay down, you have difficulty breathing, but when you sit up, you don't, and difficulty breathing. And so If these signs or symptoms appear in this type of patient, stop the transfusion immediately and start the workup. For the patient I just described, we want to give small volumes slowly. And so with my patient, with the pathologist and the physician, we decided that the best course of action was to divide the unit into two and give half over 4 hours and then give the other half over 4 hours, really slowing down the amount of blood, and then give her heavy-duty diuretics so that excess fluid can be expelled through the urine. And she did just fine. But then you want to give half, wait. Give half, wait, to allow the body to equilibrate to the increased volume and have time to get rid of excess fluid. Transfusion-related acute lung injury, also known as TRALI, is the number 2 cause of transfusion-related deaths. The chest x-ray shows acute pulmonary edema. There's acute respiratory insufficiency, but no evidence of heart failure. The symptoms of respiratory distress syndrome after the infusion of volumes too small to produce hypervolemia. This may also be accompanied by chills, fever, cyanosis, and hypotension. This occurs within 6 hours of transfusion, most within 1 to 2 hours after transfusion. And this is why the nurse needs to keep a close eye on a patient, not only during the transfusion, but after the transfusion. One study showed that 100% of patients with TRALI require oxygen, and 72% of those require mechanical ventilation as well, a ventilator. For TRALI, all plasma products have been implicated, and the reaction occurs between donor leukocyte antibodies and the recipient's white cells, as well as biologically active lipids. What happens is the donor leukocyte antibodies cause the recipient's white cells to aggregate. These aggregates get trapped in the lungs. They release cytokines which damage the lungs and cause fluid to enter the alveoli spaces. Stop the transfusion, immediately start the workup. Treatment of IV steroids calms the immune system down, as well as respiratory support due to the reaction. Prevention: blood centers do not make plasma products from female donors who have been pregnant unless they test negative for leukocyte antibodies. They'll make the red cell product, but then they'll throw the plasma away. So massive transfusions can cause a number of types of complications. Massive transfusion is historically defined as the replacement by transfusion of 10 units of red cells in 24 hours to correct blood loss due to massive and uncontrolled hemorrhage. So in the donor unit, there's CPD, citrate phosphate dextrose. So the citrate toxicity, which is the additive in the anticoagulant. Hemostatic abnormalities, transfused blood products may affect hemostasis. So this is why the docs need to be aware that for however many units of red cells, you need to then transfuse plasma and platelets and maybe even cryo to maintain hemostasis. Because when you're bleeding out this bad, you're losing massive quantities of whole blood. So in that whole blood is everything. Hyperkalemia, deletion of storage, the potassium increases in the unit, and this can cause problems with the patient's heart. Hypocalcemia, the anticoagulant prevents clotting by binding calcium. So again, the patient needs to be monitored for the potassium and the calcium to make sure that they're not too high or too low. Air embolism, which is exceedingly rare, and it would take a large bolus of air to cause you to die. Even a syringe full will not cause you to die. It needs to be a large amount, enough amount that it will fill one of the chambers of the heart to where it has no blood, and that leads to heart failure. Hypothermia, donor blood is kept at 4 degrees centigrade, and when you massively transfuse, and we're talking back to back to back to back, we're infusing as quickly as the patient can tolerate it, then they can go cold because of the temperature of the donor blood. So this table represents transfusion-related fatalities, not reactions, fatalities due to reactions from 2014 to 2018. Statistics are always a year or two behind because they have to analyze from many resources, collect, and then publish. So if you look at the very bottom line, we have Taco has 58 transfusion-related deaths in 5 years versus Trally, which is 46. When I looked at previous data for other years, Taco was number 1. So they kind of switched. So for all intents and purposes, what I want you to know, Taco is number 1, Trally is number 2. And then you can look at the other types of reactions. In my heart, I believe transfusion-related fatalities are underreported. So, yeah, it's kind of interesting. And if you look at microbial infection, devastating. There's 25 of those. That's the third leading cause of death. We're now moving on to the delayed hemolytic transfusion reactions. And this is why we have you take immunology, serology before this course, because as you've noted, all of those principles of your immune response, they apply directly to this course. So we're going to talk about or review the two types of delayed, and that's primary and secondary immune responses. The delayed transfusion reaction due to a primary immune response, if this is the immunizing event, takes weeks to months. As the antibody increases in titer and avidity, it reacts with the antigen-positive donor cells that are present. And just remember, the specificity and the avidity and the sensitivity just take time because we're slowly processing these antigens. When we first start making the antibody, we're not real good about it. So the degree of hemolysis depends on the quantity of antibody present and the quantity of antigen-positive donor cells present. Remember, a red cell lives 120 days. When you transfuse a unit of blood, some of those cells have just been born and some of those cells are fixing to die, and then we have all in between. So again, by the time you make enough antibody, usually most of those transfused donor cells are gone. You can usually it's unsuspected clinically, but you may suspect it based on an unexplained fall in hemoglobin. And if for some reason you are told to do a DAT, depending upon the timing, the DAT may be positive. And because the DAT is positive, you'll want to do the full workup. You'll do the antibody screen, which will then be positive, and there's a new alloantibody. And because it's a brand new alloantibody, the reaction will be at immediate spin. Now, there may be some at 37 in Coombs because maybe IgG is now being produced. So don't be surprised if you see an anti-Big E or an anti-Cal react at immediate spin. If this is a primary immune response due to a recent transfusion. In the secondary immune response, this is a previously immunized individual, and alloantibodies may fall to undetectable levels. So unless you've done the work on that patient at your facility, but patients move around, and I'll tell you a story in a minute, but they may not have gotten their initial transfusion with you. So they come to you, a blank page, the antibody screen is negative, so you just set up random donor blood. Within 3 to 7 days after transfusion, and the anamnestic response kicks in, the large number of antigen-positive red cells present will promote a rapid increase in antibody titer. So the symptoms, the patient will have fever, an unexplained fall in hemoglobin, and jaundice. Because these cells are breaking down, the liver can't handle the bilirubin levels, and so the patient will turn yellow. Rarely there's hemoglobinuria and renal failure. So we had a patient that he came to us for years. He had alcoholic cirrhosis of the liver, he had an anti-Big E, but what would happen is we identified it, and then it fell below the level of detectability. His antibody screens were negative, but because of his history, for the rest of his life, he needs big E negative blood. Well, I guess he got mad at us and he went to another hospital. And when he came back, his antibody screen was positive. We identified an anti-big E. The direct antiglobulin test was positive. We eluted an anti-big E. And we called the hospital. And again, because they were unaware, because the antibody screen was negative. So after that, he stayed with us. And his antibody went below the level of detectability. Most delayed transfusion reactions go unnoticed, and the transfusion service may be the one to diagnose this condition if another cross-match is ordered. The current sample then may have a positive DAT, and this is because patient antibody is coating donor cells. So when you do the DAT and you're shaking that tube, you're going to have mixed field agglutination. You're going to have a sea of free cells, which are the patients, and then these clumps, these tight clumps of cells, which are the donors. So your DAT will have mixed field agglutination. So you'll want to perform an elution so that we pop the antibodies off those donor cells and get them in a solution to test. And then we identify the antibody by running that eluate against a panel of cells. The antibody screen may be negative because as the antibody is being produced, where is it going? It's going onto the donor cells that possess that antigen. So until the antibody titer gets sufficiently high and the donor cells are sufficiently low, you will not see or detect that antibody. The antibody screen will become positive once all donor antigens are coated. This is the reason that samples for compatibility testing be no more than 3 days old at the time of testing. And this is another reason we always check patient history. Once an immune antibody is identified, the patient for the rest of their life must be given antigen-negative blood, even though the antibody screen is negative. So let's talk about this table that illustrates the chronology of a delayed transfusion reaction. So your initial testing on the patient for the cross-match, the antibody screen is negative, and there's no need to do a DAT because the antibody screen is negative. The next sample will have a negative antibody screen, and if a DAT is done at that time, the DAT will be positive. And again, the antibody screen is negative because the antibody is going on to the antigen that caused its production, which is on the donor cells. Once all the donor cells are coated, and you see the next sample, the antibody screen will be positive because there's no place else for these antibodies to go to, so the surplus will then be present in the plasma. And at this time, the DAT will be positive because the donor cells are present and they're coated with patient antibody. In the next sample, the antibody screen is still positive, but the DAT becomes negative because there's no more donor cells left. Remember, anything coated with antibody is destroyed by your body. And then finally, the last one, sometimes the patient will have the antibody for life. Otherwise, it may fall below the level of detectability and your antibody screen will be negative. And if you did decide to do a DAT, it would also be negative. I want you to memorize the chronology of the serological results when a patient has a delayed transfusion reaction. The general population gets into a frenzy sometimes and they say, oh, the blood supply is not safe, the blood supply is not safe. The blood supply has never, ever been safe. There's always the potential of transfusion-transmitted diseases. And we're going to discuss these very briefly, but just know this list is limited, that there's other infectious agents that can also cause infections post-transfusion. First, we'll discuss hepatitis. And transfusion of hepatitis A is rare. It's transmitted through the fecal-oral route. You need to bring serology back to the front of your brain. All donors are screened for hepatitis B and C, but transmission does occur because the donor may not be through the window yet. What that means is they're infected, but they haven't produced sufficient antibody to be detected. And as for hepatitis B, most people now are immunized to hepatitis B. So we don't see transmission of hepatitis B hardly ever, but hepatitis C, yes. So if this occurs, if a patient gets hepatitis, and it's either B or C, the donor is permanently deferred if their unit was the only unit given to a patient who contracted hepatitis. Permanently defer a donor if they're implicated in 2 separate cases and they were the only donor in both. So Miss Jones got my blood and somebody else's. Ms. Smith got my blood and somebody else's. And the only common denominator is me. So if they got hepatitis and I'm the commonality, then I'm permanently deferred. This is identified by look back, and this is a process where the patient's diagnosed with the disease and they provide the information to the donor collection facility, especially important to see how many times the donor was used so that we can look back at all of those patients to see what their tests are. The problem is that once the donor becomes healthy after their surgery or whatever caused the transfusion, they may see a different doctor who does not associate the hepatitis with the transfusion. We still have non-A, B, C hepatitis transmission as well. Cytomegalovirus, most at-risk population are the immunocompetent, immunosuppressed. It's transmitted by leukocytes, and we've seen a significant decrease since all blood is leukoreduced after collection. For our neonatal intensive care unit patients, our immunocompromised, immunosuppressed patients, we will give blood that has been serologically tested and be negative for CMV. Malaria, there's still no screening test available. It's very rare, but cases are rising. And travel and immigration history are a crucial part of the donation process. So that way you can exclude donors who are at high risk of acquiring malaria. Report cases to the transfusion service or the blood provider. We had a situation that there was a donor in Dallas who lied during the oral history. He had been in a country endemic for malaria, but he felt it was his God-given right to donate blood. So he donated blood. It was transfused to a patient who was very, very, very ill. And guess what happened? The malaria replicated in her body to the extent that she couldn't combat everything at once and she died. So because of his lie, the patient died, which is, to me, just should be a crime. Babesiosis is caused by Babesia species, which is transmitted by ticks. The organism multiplies rapidly in the red blood cells. Donors are permanently deferred if they have had babesiosis. And if you look at the peripheral smear, sometimes it's looks very similar to malaria. So you got to be real careful when you're determining what this organism is. Syphilis is caused by Treponema pallidum. The donor must be drawn during the brief period of spirochetemia. There's a brief period of time where the spirochetes are in your blood. The treponemes can only survive 72 hours at 4 degrees centigrade. So the chances of blood being transfused within 72 hours is very uncommon because of all the testing that must be done prior to releasing it to the hospitals. The serological test for syphilis is negative in primary syphilis. A positive serological test for syphilis indicates high-risk lifestyle activities, which is why donors would be deferred because you're not... How do you acquire a sexually transmitted disease? Through unsafe sexual practices. How is HIV transmitted? Through unsafe sexual practices. Chagas disease is caused by the organism Trypanosoma cruzi, which is transmitted by the reduvid bug, which is also known as the kissing bug. And what happens is that the bug bites you and then it poops, and in that poop is the Trypanosoma cruzi. The disease is primarily found in Central and South America. A few cases have been reported in Texas and California due to travel between the countries. It's the cause of 30% of adult deaths in Brazil, and that's because it infects the heart. And once the damage is severe, then unfortunately the person will die. Toxoplasma gondii causes toxoplasmosis. This is a really unusual complication in immunosuppressed patients. Lyme's disease is caused by Borrelia burgdorferi, which is transmitted by a tick bite. This may be a potential problem, but no cases have been reported. We covered transfusion-associated graft versus host disease in the immunology course. This is a rare but usually fatal disease in immunosuppressed patients. Donor lymphocytes will engraft in the recipient. So the donor lymphocytes were passengers in that transfused blood, and then they engraft in the bone marrow. And then they look around and they say, this is not my body, and I don't like it, because they consider the recipient foreign. So they mount an immune response. They start producing antibodies against the patient's tissues. Pre-transfusion irradiation should be done to prevent disease for the following: intrauterine transfusions. Anything that they're exposed to in utero, they accept as self. The lymphocytes won't be rejected and may engraft. Patients identified as being at high risk for transfusion-associated graft versus host disease. This is usually severely immunocompromised patients. They don't have the ability to identify those lymphocytes as foreign and destroy them. Cellular components donated from relatives, really sad case. They knew, mother, father, brother, sister, but the uncle went ahead and donated blood for, I don't know if it was a niece or a nephew, and unfortunately that child did develop graft versus host disease and died. Since then, if you are in any way, shape, or form related to the patient, you will not donate the blood to them. And transfusion of HLA selected products. So there's a special machine they have, and it's usually one per city because it's very, very expensive, and they will irradiate the blood. It has a little purple sticker that indicates it has been successfully irradiated. The last delayed adverse effect we're going to talk about is post-transfusion purpura. This is a rare event occurring almost exclusively in multiparous women, meaning women who have been given birth to 2 or more children. The precipitous fall in platelet count with purpura occurs about 1 week after transfusion. So look at the picture. The difference between petechiae and purpura is the size of the dots, but each dot represents a bleed from a capillary, and this is usually due to a severely depleted platelet count. Some are caused by anti-HPA-1a. This antigen has 98.3% prevalence, so only 1.7% of the population is at risk for developing this antibody. And the really, really weird thing is that this antibody destroys not only the transfused HPA-1a positive platelets, but the patient's own HPA-1a negative platelets. It's bizarre. Thrombocytopenia is severe, so platelet transfusions are no help because they're going to destroy the transfused platelets just as quickly as the other platelets. And the good news is it's self-limiting. It occurs for a while, and then it's gone and doesn't happen again. Exchange plasmapheresis is the last gasp treatment, and plasmapheresis is where they hook you up to a machine. They go ahead and take a unit of blood, spin it down, remove the plasma, and it's thrown away. Return the red cells along with saline or some other type of compatible solution. And so what happens is in the plasma, there's all this antibody. So they're throwing the antibody away, decreasing the amount of antibody, and then you can replace it also with regular donor plasma. So that's called an exchange plasmapheresis. And unfortunately, there can be a rebound where the antibody titer does not only come back, but comes back higher. So it may need to be repeated. This table summarizes the most common adverse complications of transfusions into appropriate categories. Immunologic has to do with antibody-mediated reactions. Non-immunologic, just as it says, antibodies do not play with these types of reactions. And then infectious. This brings us to the end of Unit 12. Be sure and bring your questions to class.